please. This is a bicarbonate buffer. Almost 50% of our body which regulate automatically when occurs acidosis, minor acidosis and alkalosis. Then it is this is regulated by the buffer system, and most important buffer system is bicarbonate buffer system. Next, please. Hemoglobin buffer is also occur, but in a very less amount. Next, please. Respiratory regulation. When acidosis occurs in our body, then carbon dioxide, a big amount of carbon dioxide occurs in our body, then our lungs regulate by the hyperventilation. When we do the hyperventilation, then carbon dioxide expel out and our acidosis becomes normal. In next, please. In alkalosis, when alkalosis occur more, then what happen? Then hypoventilations occur. In hypoventilation, carbon dioxide excess, carbon dioxide inhale, retain in our body, and then alkalosis occur. Next, please. Renal regulation. How renal regulation occurs in acid-base regulation? Reabsorption of bicarbonate in renal tubule occurs, and then alkalosis becomes normal, and excretion of acidosis, when acidosis becomes more, then hydrogen excretion occur from the body, and these all happen from the renal system. Next, please. These are the Henderson-Hasselbalch equation. Next, please. Classification of acid-base disorder. These are almost 5 types of acid-base disorder: metabolic acidosis, metabolic alkalosis, respiratory alkalosis, and respiratory acidosis, and mixed type. Next, please. Next, please. Then, when pH becomes less than 7.35, then acidosis occur. And when pH is more than 7.45, then alkalosis occurs in our body. Decide whether it is how diagnosis we make when the changes of P in bicarbonate, then it is known as the metabolic alkalosis or metabolic acidosis. When changes occurs in the level of carbon dioxide and bicarbonate becomes normal, then this is called respiratory alkalosis or respiratory acidosis. Next, please. In respiratory acidosis, pH becomes less, that is less than 7.35, and bicarbonate is become normal, and PO2 level becomes more. And in alkalosis, pH is more and PCO2 becomes less. In metabolic acidosis, what happened? In the changes of bicarbonate occur, and this occurs in the same direction. Like metabolic alkalosis when occur, then pH is less, pH becomes more, and bicarbonate level also become more. And in metabolic alkalosis, pH becomes less and bicarbonate also become less. This is the ABC finding. Next, please. In a respiratory acidosis, it is opposite. That is, pH and CO2 level becomes increases in opposite direction. But in metabolic alkalosis, it happens in same direction. Next, please. In metabolic acidosis is called when it is level is less than 7.35. Next, please. Excess acid production, loss of bicarbonate from the body, reduced renal acid secretion, all these occurs in metabolic acidosis. Next, please. In high anal gap metabolic acidosis, diabetic ketoacidosis occurs, lactic acidosis, renal failure, and poisoning in methanol or ethyl glycol. All these in conditions, these metabolic acidosis occurs. Next, please. Normal metabolic acidosis conditions are in diarrhea, renal tubal acidosis, post-ureteric diversion, excess saline infusion. Next, please. Clinical features occurs in metabolic acidosis, Kussmaul breathing. Patient take in hyperventilation, जल्दी सांस लेता है, and hypotension occurs, hyperkalemia, decreased cardiac output, altered consciousness. All these occurs in metabolic acidosis. Next, please. In management, first of all, we treat the underlying cause and give the IV fluids, insulin therapy for diabetic ketoacidosis, soda bicarb, and dialysis if needed. Next, please. Metabolic alkalosis. Diagnosis made by the less than 7.45. Next, please. Causes are gastric acid, more formation, diuretics, hyperaldosteronism, excess of alkali intake. Next, please. Clinical feature occurs in metabolic alkalosis, muscle twitching occurs, tetany, hypokalemia, arrhythmia. Next, please. Volume and chloride replacement for management, potassium supplementation, stop offending drugs, treat endocrine causes if occurs. Next, please. Respiratory acidosis. One primary elevation of PaCO2. In respiratory acidosis, bicarbonate level becomes normal, but the carbon dioxide level becomes more. This is a difference between the metabolic acidosis and respiratory acidosis. In respiratory acidosis, carbon dioxide level raises, and metabolic alkalosis, bicarbonate level becomes more. Next, please. Causes are COPD, severe asthma, CNS depression, neuromuscular disorder, chest wall abnormality. These are the main causes. Next, please. Management, airway management, oxygen therapy is given in respiratory acidosis, non-invasive ventilation, mechanical ventilation if needed. Next, please. This is the last respiratory alkalosis. In respiratory alkalosis, pH level becomes less than 7.35, and in respiratory alkalosis, hyperventilation occurs. That means patient जल्दी सांस लेता है. Next, please. Causes are anxiety or panic attack, hypoxia, sepsis, pregnancy, liver failure. All these causes are respiratory alkalosis. Next, please. Clinical feature occurs like lightheadedness, perioral numbness, ओठों के चारों तरफ कुछ tingling sensation, caropedal edema, reduced cerebral blood flow. All these occurs in respiratory alkalosis. Next, please. Treat the underlying cause, reassurance and sedation if required, and correct hypoxia or sepsis if there are sepsis. Treat the sepsis or underlying cause if there are. Treat the cause of that particular cases. Next, please. In ABG stepwise we take, first we perform the arterial blood gas analysis, then we assess first pH, where pH is low. If there is low, then it will become the acidosis, whether it is a metabolic acidosis or respiratory acidosis. Then we decide carbon dioxide level and bicarbonate level. If bicarbonate level is increased, then it is a respiratory acidosis. If bicarbonate level is less, then it is a metabolic alkalosis. In respiratory, if carbon dioxide level is more and bicarbonate level is normal, then it is a respiratory acidosis. And if pH is more than 7.45 and bicarbonate level is also increase, then it is a metabolic alkalosis. We make a diagnosis like this process. Next, please. It may be a common in critically ill patient. It may be respiratory acidosis and respiratory alkalosis also. Then we diagnosis make like that. In that situation, respiratory acidosis, it may be carbon dioxide also raised and bicarbonate level may be down. Then it will be a mixed type of, that is respiratory acidosis and respiratory metabolic alkalosis also. Next, please. Clinical case discussion, like a septic patient. Suppose that pH is 7.28. Just last slide. Low PCO2, low bicarbonate. In this situation, next please. This is a mixed type of, that is a metabolic acidosis and respiratory alkalosis. Next please. Key take home, that is acid bed disorder occurs in ICU. In ICU, first of all, we take a history and then we decide whether it is the level of carbon dioxide is increased or level of bicarbonate is increased. We make a diagnosis on that behalf and then we should treat whether it is a metabolic alkalosis or metabolic alkalosis. Thank you.
Thank you, Dr. Jaswal. Because it was a oration lecture, so please no questions will be asked. Now, Dr. Swati will invite the next guest speaker. Please be seated.
Thank you, sir, for that insightful presentation. Now, I would like to introduce our next guest speaker, Professor Dr. P. Hemanta, sir. Sir completed his BMS from NTR University of Health Sciences, MD from Banaras Hindu University, and PhD from NIA Jamnagar. Sir, having more than 27 years of teaching experience and clinical experiences, sir having 124 research article publications, sir attended more and more workshops, webinars, 30 CMEs, etc. Sir also received several prestigious awards. I requested to you, sir, please. Dr. Hemant, sir, please.
Yes. Om Dhanvantaraya Namaha. Om Anjunadaya Namaha. Respected dignitaries on the dais, my dear students, and respected chairperson, and organizers giving chance to me to share my knowledge in front of you. See, the symposium, that is the conference, is surgical concepts of Shalya. Okay. See, today what you are seeing, my time is 15 minutes. You see that? My time is 15 minutes. You can calculate it. There are 200 slides are there. There are 200 slides are there. I will complete within 15 minutes. Asukriyat. Okay. This is the surgeon's target. Okay. You see, these slides are, it is my last 28 years experience with the surgical concepts of Susruta with present current scenario. This is our institution, National Institute of Ayurveda. It's the first college in India, Quality Council of India. It's a A-grade college, NAC accredited, NABH accredited from Ministry of Ayush. See, before going to that, these are the facilities available in our department, Shalya. OPD, I am proud to say that anorectal OPD per day, around 250 to 300 patients we are coming to our OPD, and more than 15 procedures we are performing daily. Orthopedic and Marma Chikitsa unit. Another very important, nowhere in India, orthopedic and Marma Chikitsa unit, and we are conducting our institute, endoscopic unit, IPD, OT, at present OPD. So this is my vision of the Shalya Tantra, hand-to-hand surgical training program. See, this is very important. Hand-to-hand surgical training is very important for surgeons, just like a medicine. See, you never imagine, you can see that above is my hand, below is my PG scholar hand. I request all the departments of Shalya Tantra in India, you start your own logo of this hand-to-hand. At least आपको मन में लगेगा मेरा स्टूडेंट्स को मैं ट्रेनिंग करना है. ये इंपॉर्टेंट है, आपको सीनियर टीचर सर्जन का साथ हैंड ले लो, जूनियर टीचर को हैंड ले लो, ये बना दो. This is a very important. I am giving one example. So many hesitations for this emblem, and especially usually for the college it is there. Department wise there is nothing. There is no separate logo. But we started in NIA, and all NAC committee appreciated about this logo. You never imagine now all 14 departments they developed logos in NIA. See, major surgeries we are performing, minor surgeries, orthopedic, plastic, anorectal, minor surgical, marma chikitsa, rakta mokshana, agni karma, Sharasutra Kshara karma, laparoscopic. I think I am very thankful to my senior Sivaji Boss. We started, this is my dream in my life, to start laparoscopic procedures. You never imagine, we started in 2022. Sir came to our as an examiner in NIA. Already we purchased in 2020 because of Corona. We not possible to do for under GA. Then you never imagine more than 95 cases we completed laparoscopic cholecystectomy by Ayurvedic surgeons. Laser surgeries and videorectoscope, fistuloscope. And we have a Yoga Vidhi. There is a simulation lab, around more than 25 crores simulation lab is there. The concept of Susruta. See, this is the advanced mankind, CPR. And this is my dream project. This is already last 5 years I am showing out this slide to all the conferences. Now laparoscope simulator sanctioned. And next month we are going inaugurate in our institution. The cost of laparoscopy simulator is 3.5 crores. This is another dream of myself and my Vice Chancellor sir, cooperation. Modular operation theatre. There are 3 modular operation theatres are going to inaugurate next month in Shalyakan 2K26. One is for general surgery, number 2 for orthopedic, number 3 for anorectal surgery. Okay, this is the modular OT, and these are the gradual increasing of OT procedures in our NIA. Number question, surgery is there or not? Usually question asked by every person. Maybe the question are received from your colleague or same family member or your father or mother. Is a common. एक question मेरा के लिए पूछेंगे तो वो मर गया. ठीक है? वो मतम खत्म. Why? Because if the person asking about your Ayurvedic surgery हो तो सुश्रुता से मेरा तक बताना पड़ेगा इसको. ठीक है? It's very important. Surgery is there. Okay. Our degree is not BAM. Our degree is BAMS, Bachelor of Ayurvedic Medicine and Surgery. Okay? And MS Ayurveda specialty. And these are the schools. Shalachandra is a very important branch. And Susruta is the father of surgery. Authentative textbook of Susamhita. First, cadaveric dissection mentioned by Susruta. All principles of Susruta's concept till practicing now. That is Saurya Masukriyat Sastratikshna Asvedu Vepada Sammohocha Vaidyasya. Then surgical diagnosis. So many textbooks they mentioned about our concepts of Susruta, Shadvida Pariksha, Yogya Vidhi, surgical instruments. One of the example I am giving for laparoscopic and endoscopic procedures on the basis of Nadi Yantra, Roga Darshanardham, Achushanardham, Kriya Saukaryardham, and Srotogata Shalyodaranardham. Then instruments, all instruments are invented or designed by Susruta. The material may be different. Concept is similar. Hastamayo Pradhana Yantra, heat sterilization, already explained by Susruta. Still we are following different type of sterilizations. What are the procedures? Maybe laparoscopic, maybe microsurgery, or maybe robotic. This comes under 8 Sastra karmas. All Chedana karmas, appendicectomy, gallbladder. See, this is a very interesting case. We operated 2 gallbladders, but usually it is not a 2 gallbladders. It is a stone stuck at the Hartmann's pouch. These are multiple stones we operated. Lipoma, excision, intra-abdominal lipoma, neuroma. It's a very rare case we operated. Or the brachial neuralgia. That's especially brachial plexus. Penile amputation under local anesthesia. Mastectomy, CA breast, thyroidectomy, orchidectomy, and incision. All incisions comes under the concept of Sushruta. Till today, radial incision is explained by Sushruta. We are following for breast abscess incision. And this is a very rare case, 20 days female baby of incision and drainage of breast abscess. Vedanam panchakarma, puncturing, probing, all extraction procedures, foreign bodies, fetus, etc. And lekana karma, visravan karma, suturing materials. We conducted some of the herbal suturing materials in our institution like Morva, Guduchi, surgical thread coated with Guduchi Swarsa. These are the suturing materials. And another thing, importance of emergency surgery also is there. So many specialties are there: gastrointestinal, urology, proctology, gynec, obstetrics, ENT, ophthalmology. So many surgical specialties mentioned by Sushruta. Till we are practicing GIT surgery, all incisions of the abdominal laparotomies mentioned by Sushruta. And Pipilika Prayoga, it's the first biological absorbable suturing material mentioned by Sushruta, the concept given to the world. DU perforation, gastrojejunostomy, sliding inguinal hernia with obstruction, and paraumbilical hernia. It's a very huge 2 times, 3 times operated by modern counterpart. We did this case open method, hernioplasty, epigastric hernia, femoral hernia, giant ovarian tumor, more than 6 kgs ovarian tumor. And this is another interesting case of mesocolonic lipometastasis, 9 years female patient. See, huge, just like a pregnant lady, we operated this case. And a huge watermelon hydrocele trauma. This was concept also given by Sushruta. Till we are treating trauma cases also, like Chinnam, Binnam, Viddam. These are the phalangeal injuries, cricket ball injuries followed by the orchidectomy. Then Pranashtashalya. This is also a very interesting case we have seen. Very difficult to identify. This is 20 years back. That time there is no CR facility. We designed for a graph, Yukti Pramana. Then identification of the foreign body. Then we removed within 5 minutes. This is a very important case, structure of foreign body. Orthopedics. What is plaster of India? Everybody knows about the plaster of Paris. And we started this work first time in India. That is called Manjishtadilepa. Manjishtadilepa is a plaster of Paris. It is mentioned in Bhagna Chikitsa. Management of Bhagna, Anchanam, Pedanam, Sankshepam, Bandhanam. We are using not in POP, we are using Manjishtadilepa. So we conducted so many studies in ankle sprain with Manjishtadilepa and intramedullary nails and proximal finger phalanges fracture, displaced, and open reduction, internal fixation with wire, and bun contractures, syndactology, skin graft we did, jet plasty, and amputations, all types of amputation we are performing, great amputation. This above knee amputation, very interesting case, unfit for surgery, unfit for anesthesia. We did first case, almost last case till my practice. Under local anesthesia, we did above knee amputation. Patient is still live. This is above knee amputation, local anesthesia, plastic surgery. These are the principles of plastic surgery: rhinoplasty, oroplasty, otoplasty, and skin grafting, and urology. First consent of the patient, first mentioned by Sushruta, Akriyayam Dhruvam Mrityum Kriyayam Samsayo Bhavet, Paniyakshara in calculus. And we did suprapubic cystolectomy. That is also another contribution of Sushruta, perineal cystolithotomy. Now we are practicing suprapubic cystolithotomy. And proctology, everybody knows about that. This symbol of proctology, Anguliyavam Pradhana Yantram Gudavikara. Who mentioned? Correct, Sushruta Bhagbat. No, it is mentioned in Hemanta Samhita. I created this finger off. Finger is very important. Why? Because without finger, we can't diagnose the anorectal diseases. Okay. You accepted or not accepted? Google accepted. Finger is the best for proctology. See, these are the anorectal cases. Hemorrhoidectomy, fistulectomy, these are all the names given, but the concept and everything, procedure is given by Sushruta. And abscess followed by Ksharakharma, 4 years gangrene, and parasurgical procedures like Ksharakharma in hemorrhoids, histopathological study, Charakarma in abscess, Charakarma in pilonal abscess, Charakarmas we are practicing rectal prolapse. I designed a small instrument for modified sphincterometer for assessment of the anal tonicity, sphincter tonicity. Fistula is a conventional Charasutra therapy, and it is mentioned in all the textbooks of surgery like Bale and Love, Manipal textbook of surgery. There is references are there. And recently, 10 years back, we started work on MIKST, minimal invasive Charasutra technique. It is interceptive technique. I invented in 2015 in NIA, and recently it is published in Annals of Medicine and Surgery. You never imagine Annals of Medicine and Surgery. It is the one of the 6th place in global publications. 6th place in global publication. It's very difficult to publish this journal, especially for Ayurvedic surgeons. And 1 year I reviewed, and 46 or 48 reviews I received, accepted in this year in February. And you never imagine after acceptance, the cost of publication is 1,80,000. 1,80,000. I am the first person received 1,80,000 from Ministry of Ayush. Why? Because it is not only for government sector, practitioners also, private colleges also, we can, if you publication in a reputed journal, you can apply and you can get the money. Okay. This is a very important procedure for fistula and nano. So these are the things. 215 retrospective data we given. And this is the simplest technique. You can see that this technique is what my inspiration of Kiftak technique by Sahu sir. And this technique, what happened, 10 centimeter tract we can cut at 2 centimeter at interspintic groove. Remaining tract we can leave it. One-minute video. Okay. So this is the fistula tract. You can see identification with hydrogen peroxide betadine to know the internal opening of the fistula tract. You can probing from external to internal probing. Then थोड़ा fast करना है इसका, थोड़ा clip fast कर. Over. थोड़ा fast करो clip. Then intercept at the intersphincteric groove. That is most important. You can see the intersphincteric groove in between the internal sphincter and external sphincter. Then you can divide into two parts: proximal fistula tract, distal fistula tract. Proximal fistula tract is applied by Charasutra. Distal fistula tract, you can remove the core fistulectomy, or you can leave alone, or you can apply the plain thread also for drainage purpose. See, this is the fistula tract. You can see that. It's very important is identification of the intersphincteric and external sphincter is very important. Then we can cut into two parts. उस स्लाइड के ऊपर थोड़ा फास्ट करेंगे तो हाथ से कर सकते हैं. वो टच पैड है, थोड़ा कर लो. You see, remove the probe and first primary threading followed by the Charasutra. Then you can apply for the primary threading. Okay. Okay. This is the simplest technique. That means duration of the treatment of the fistula tract 10 weeks to we reduce to 2 to 3 weeks. This is the simple ambulatory treatment and no minimal post-operative pain. and no post-operative lengthy visits and ambulatory procedure. Next slide. This another technique we invented, this MIKKT, minimal invasive Kshatrakarma technique in PNS. These are simple technique in pulmonary sinus. See, usually we never go for wide end of the PNS. We can go for 2-3 openings where the pits are there. Go for the skin biopsy. Skin biopsy forceps is there. Then you can go for that and application of the Kshara. So you can see that clearly. We can see that. This is also published in international journal, index journal. And clinical findings, you can see this is another interesting case. Rhomboidoplasty followed by fistula in ano and recurrence of the case. We treated with MIKKT. This is also published in index journal. These are the follow-up cases. This you can see that completely healed. Another very important thing, these two techniques along with Sausar technique, IFTAC technique enter into the syllabus of NCISM, and we can see the new syllabus. The Agni Karma, Rakta Mokshana, leech therapy, Srungavacharana, maggotification also we tried MDT, maggot debridement therapy, a Susuta's technique, Marma Chikitsa, see before and after treatment of frozen shoulder. See, gadget already you know more than 38 procedures you can practice by general surgery, especially for MS, Yavai Shalitantra PG scholars. These are all documentation from 1998 to till today. Around 17,872 major cases documented in our operation theatre. This is our future of Ayurvedic surgery. Last slide. We don't know in future robotic Charakarma, robotic Charasutra, robotic Agni Karma, maybe it will come. So these are all my real Susrutas. I think I have not seen the Susruta seen by statue, but Susruta I have seen in my teachers, seen in my seniors, seen in my students also. I learned so many things from my Susrutas. All surgical concepts and procedures are Indian contribution to the world science. Not world contribution to the Indian science. Indian contribution to the world science. Thank you. This is our teamwork.
Thank you, Dr. Hemant. If there are any questions from the audience?
Only one question, please conclude.
Anyone? One question we can have, one quick question. Okay, it's okay, please come.
Thank you.
Thank you so much, sir, for this insightful presentation. Now, sure. Sir, having a question.
Actually, clear बताएंगे. IFTAC technique, I think Sahu sir more than 2005-6 से practice शुरू किया है, and he is the real interceptive technique to develop other interceptive techniques. Interceptive techniques साथ develop किया, but IFTAC technique learners are very difficult to practice. आप जस्ट पीजी पास होने के बाद आप IFTAC टेक्निक करना वेरी डिफिकल्ट होता है, ठीक है, बट MIKST करना इजी होता है. नंबर 1, IFTAC टेक्निक इज ओनली फॉर कॉम्प्लेक्स फिस्टुलास. Complex fistulas means especially anterior horseshoe shaped fistula, posterior horseshoe shaped fistula, gluteal extension is a window technique. Here there is no window technique. Number 1. By IFTAC window technique, we can daily go for the drainage and cleaning of the wound. But in MIKST, there is no cleaning of the wound. But MIKST is not for all the cases. In complex fistulas, I am following IFTAC only. This MIKST is only for the transpentric fistulas, mature tract fistulas, clear fistulas, we can go for that. But MIKST can do total crack, 1, 2, 3, 4, 5, 6, 7, 8, anywhere. But IFTAC technique, window technique, either anteriorly or posterior. Okay, both are interceptive techniques, but pattern is different, indication is different. Okay, thank you.
Thank you, sir. Now it's time to introduce our third guest speaker, Professor Shuji Gupta sir. Sir, currently posted as a professor in Department of Shalya Tantra in Banaras Hindu University. Sir completed this BMS from Kanpur University, MS and PhD from Banaras Hindu University. Sir having more than 26 years of teaching and clinical experiences. And sir having more than 24 years of research experience. Sir has guided 20 MD and MSc scholars and 3 PhD scholars and different and number of diploma scholars. Sir published more than 55 publications and sir also received different type of prestigious awards. Sir, please. Sir, now I would like to invite Shuji Gupta sir for the lecture presentation. Sir, please.
Thank you, Dr. Dibyani, for my very nice introduction. Respected chairpersons, Professor Ajay Kumar Gupta ji and Dr. Pankaj Kumar Bharti, and the learned guest speakers, Professor P. Hemant Kumar, the keynote speakers, the orators, Dr. R.K. Jaiswal, and the senior faculty members sitting in the hall and dear students. Before going to start my presentation, I am very much thankful to Dr. P. Hemant Kumar. He has completed his talk within his, whatever he said within time. Generally, it is not happen in everywhere. It takes more time for detailed description of their institute and work. Definitely, we will do it for the propagation of the Shalya Tantra. Otherwise, the new budding doctors are not be stimulated. So, for the stimulation of these things, his talk is very, very important for new beginners. So, my talk is based on the Char Sutra therapy. Generally, it is a very popular procedure for all Salya people. But here I only focus on the what we do and what we not do in case of Char Sutra therapy, especially in the management of the fistula in ano. There are several things there is very small things we forget during the management, but if we take care for the these things during management or during the period of the Char Sutra therapy, the result is definitely very positive. Positive in sense ki we reduce the time period of the Char Sutra therapy, which is the one of the एक तरीके से कहें कि it is the drawback of the Char Sutra therapy. Generally, people say it takes long time for the treatment period is very, very long. But we reduce this treatment period from long to short. The another pitfall is pain. Generally, if the person suffering from fistula, there is mild pain during the disease course, but when we plan for the Char Sutra therapy, the nature of pain slightly increases during the whole length of the therapy. And sometimes it is very painful for the patient, but he has एक तरीके से कहें कि उनके पास कोई ऑप्शन नहीं है तो इसलिए वो ट्रीटमेंट करते हैं, बट इट इज नॉट द वे. सो वी थिंक ऑन दैट कि हाउ वी रिड्यूस द pain during the Char Sutra therapy. So if we follow this technique for the we take care during the post-operative therapy of the Char Sutra, definitely we reduce the pain during the Char Sutra therapy, and also we reduce the total duration of the time during the Char Sutra therapy. So what is problem? हो रहा है? अब तो आपके लैपटॉप से हो रहा है. ठीक है, डायरेक्ट करिए. ये इसे मैनेज
हाँ वहीं से हो जाएगा, हेमंत इससे कर देगा। आगे
ठीक है,
आगे
ओके
start.
आगे डन।
वहीं से बोल दीजिए।
ये आ रहा है हो रहा है चेंज हो रहा है।
उधर से करवा।
Technology sometimes help more, but sometimes it
Yes yes yes.
act as obstacles.
देख लीजिए प्लीज क्या हो रहा है, क्या प्रॉब्लम हो रहा है।
So before taking much more time, we all know what about the fistula. The fistula is defined as a granulation tract between the fistula in ano defined as a granulation tract between the anorectum and perineum. Next, and as per management, या तो हमारे हाथ में कंट्रोल दीजिए, ठीक है। Many fistula are low lying as per their presentation and consisting a single straight tract from the skin to the anal colon. Such type of the fistula is not problematic in sense that it is well treated by any procedure. Either we did surgical excision like fistulectomy, fistulostomy, or simple Charsuth therapy or laser therapy, whatever you plan for the simple fistula, the result is very good. It is not a very specialized way to treat such a simple fistula कि हम कहें कि नहीं क्षारसूत्र थेरेपी बढ़िया है, ऐसा नहीं है. But the problem is in some fistula when it is complex in nature. Complex in nature, that means that there is more involvement of the musculature, the sphincteric musculature, or it is trans-sphincteric or supra-sphincteric level, having there is several ramifications, so it is difficult to treat. And in that cases there is we make a balance. If we go for the complete eradication of the infectious things, that is like in cryptoglandular infection, if we try to eradicate this cryptoglandular infection in a exhaustive manner, there may be favorable chances of the damaging of the sphincter. And if we try to preserve the sphincter, there may be favorable chance for there some sepsis may be losses in the body, which is cause of the recurrence. So it is difficult to make a balance between these two things for preservation of the sphincter and simultaneously to complete eradicate the sepsis, which is the more culprit for prevention of the recurrence. So in present scenario, in that scenario, the Charsuth therapy is definitely a very play an important role for the curation of such type of the complicated disease. So simple fistula, there is nothing problem, but challenge in complex fistula. Now we comes on the Ayurvedic view. Ayurveda also, Susuta also suggests the first line of treatment for the Bhagandar is Chedya, that is the excision, complete eradication of the fistulous tract. But why these things? If you go through the indication of the Char Karma or Char Sutra, it is not a general practice for the management of the fistula. It is specialized, designed for some specific person, which is mentioned in this sloka. I'm not going in detail for the detailing this, but it is designed for in a specific condition, not for the all. So why the Charsuth therapy for the treatment of fistula in present scenario is considered as a gold standard, and it is populated not only by Ayurvedic people, but it is well accepted by the modern surgeon also for the management of the complex fistula and there are several centers in India. The one is the All India Institute of the All India Institute of Medical Sciences, AIMS, Delhi, and another we know the Chandigarh, the Government Medical College, Chandigarh. They well treated the fistula of by the Charsuth therapy. So why it is popular? Because there is several factors which is responsible for the popularization of the Charsut therapy. There is no hospital stay except in few conditions, few specific condition where there is need of the specific dressing during the post-operative period. Patient can perform his or her routine duty or routine work, even though if the we took the 3 month, 4 month or 6 month, but we never be advised to the patient to take rest during this period. They do all the work, whatever their work routinely. There is very low recurrence rate. I'm not saying the zero recurrence rate, because there is some recurrence even though after the Charsut therapy, but it is very, very negligible in percentage. It ranges 0 to 1% or 2%, or in some study approximate the 5% recurrence rate. Maintenance in sphincteric mechanism. There is a study in the Banaras in the university, the pre-therapy, Charsut therapy in sphincteric mechanism, and after the Charsut therapy, whatever the sphincteric mechanism, there is some sort of the loss of the sphincteric mechanism we noted, even though after the Charsut, because the especially in transsphincteric fistula, the both the musculature comes in between the Charsutra ligature and it gradually cut, but simultaneously it gradually healed. So there is some sort of the loss of the sphincteric mechanism in transsphincteric fistula, but even though the patient can maintain his or her continence, there is in some cases the flatus incontinence may be noted, but fecal incontinence is not noted. So we not say ki it is not a sphincter saving mechanism in transsphincteric fistula. So on that basis we can say it is a gold standard for the management of the fistula in an. It is not working. आप चेंज कर दीजिए. So I'm not highlighting the mechanism of action of the Charsutra. It is well established concept. It is not a newer concept, but there is 2 to 3 things which is essential. It irrigates the infection by the nature of the char, Charaniti chara. It dissolves the tough fibrous tissue by this action, and simultaneously due to the presence of the thread inside the tract is facilitated to drainage whatever is not needed. This is the septic substance drain out easily by the presence of the thread, and healing is the natural process. It promotes, if the infectious substance are drained out, the healing automatically proceed. So I always say to the Salya people or other practitioners who practice the Charsut therapy, the passing of the thread probe through the external to internal opening is not the aim of the Charsut therapy. We think many more during the Charsut therapy. In our residency period, such type of the practice was there, but due to the development of our science and technology, and we think more and more on that subject, then we find out no, only the passing of probe from external to internal opening is not the aim of our therapy. There is some different thing. We think many more during therapy, and we consider these things when we plan the treatment. So, as per the Finlay et al., the objective of the management of the fistula in, he defined that there is 5 objectives of the management of the fistula in, to define the anatomy of the fistula, to drain any associated sepsis, to eradicate the fistula tract. It was by the Finlay, but here we not stick the third fundamental principle. Here we never think about the whole length of the fistula tract, but the importance is to eradicate instead of the fistula tract, to eradicate the primary source of the infection, that is the cryptoglandular infection. If we eradicate the primary source of the infection, so there is no need of the excision of the whole length of the fistula tract. On that fundamental principle, the newer technique, either IFTAC or MIKST, whatever the adopted by Professor P. Hemant Kumar in NIA, All these things are based on that to eradicate the primary source of infection. Now the क्या हो रहा है भाई? Why these things? So the second last is to prevent the recurrence and to preserve the continence. The first aim and objective is to define the anatomy of the fistula, that not the normal anatomy of the anorectum, but their ramification, their direction, their branching, and any associated pathology which is related to the fistula state. We all these things assess before starting our treatment. So the another concept, it is totally based on the Susuta's concept to drain any associated sepsis. In inaugural function, Professor Sunil Joshi already stated these two sloka. This is the good example of the counter incision. If the sepsis is not eradicated by single incision, the Vaidya or surgeon should perform the counter incision. And another example of the multiple incision, yato yokto gatim vidyut sang yatrat cha tatra tatra vranam kuryat, wahan vran karna chahiye. The main aim and objective of total therapy is yatha doso natisthati. This is the main objective. The whatever the sepsis, it should not be retained inside the body. It should be drained properly. Otherwise, there may be chance of the recurrence. So we work totally on the fundamental principles of the Susruta, whatever he described 1,000 years back. It is still alive, and we practice on that principle. So eradicate the primary source of the infection. Definitely, we eradicate the cryptoglandular infected crypt. It is generally located, in most of the cases, it is located in the intersphincteric area and mostly at 6 o'clock position, or in some cases it may be anteriorly. So in that, so another is to prevent recurrence, to preserve continence. Here I am showing the one of the case which is operated by modern surgeon, and you can see here, even though in normal position the anal canal open, it is not be constricted. Here total sphincteric loss. If we try to eradicate the source of the infection, there may be fair chances of the loss of the sphincter, which is not desired. It is not our aim. We not तो हम पेशेंट की लाइफ को और दुस्तर न करें, बल्कि उसको बनाने की कोशिश करते हैं. So by this, if we treat the fistula by the Charsu therapy, we think we do all these things very carefully. First thing is the proper assessment of the disease, जिसको हम बोले कि assessment of the anatomy. So we assess the proper assessment of the disease. Why there is a fistula? It is cryptoglandular or non-cryptoglandular or some other pathology associated or not. We think about that. Planning of treatment is another key point of the Charsu therapy. None of the technique is fit for all the fistula, even though if TAC or MIKST. Dr. Hemant already said it is not fit for all. I am saying here we are practicing IFTAC technique in different fistula, especially in complex fistula, but it is not be fit for each and every fistula. Similarly, the other simple conventional therapy or fistulectomy with the Charsu therapy, it is also not be fit for all. So we think what procedure is suitable or fit for particular condition of the fistula, then we plan accordingly. Regular follow-up and counseling of the patient and attendant, it is very, very important component. Before we starting the treatment, we not only counsel the patient, but also his or her attendant, because it takes long time. Sometimes patient attendant are very much under fear कि अरे क्या हो रहा है, इतना समय क्यों लग रहा है, कहीं कुछ और प्रॉब्लम तो नहीं है, डॉक्टर समझ रहा है कि नहीं समझ रहा, like that thing. So for that we counsel the patient and his or her attendant very confidently कि मैं जैसे हम लोग अपने सेटअप में हर पेशेंट के अटेंडेंट को और उसको समझाते हैं कितना समय लगेगा. लगभग हम थोड़ा सा अगर जिसमें 2 मंथ लगना है उसमें 3 मंथ कर बताते हैं कि उसका जो है थ्रेशोल्ड थोड़ा सा बढ़ा रहे. पेन थोड़ा बहुत हम बताते हैं कि भाई ड्यूरिंग कोर्स ऑफ द थेरेपी आपका पेन, डिस्चार्ज, ये सब बढ़ जाएगा. तो और और उसके अटेंडेंट को भी बताते हैं कि इस तरह की थेरेपी है, बट इट इज ए पार्ट ऑफ ट्रीटमेंट, नॉट द कॉम्प्लिकेशन ऑफ द ट्रीटमेंट। ठीक है, कई बार ये समझता है पेशेंट कि अरे मुझे कोई कॉम्प्लिकेशन तो नहीं ना हो रहा है, डिस्चार्ज बढ़ गया, हमारा ब्लड ज्यादा आ रहा है, पस ज्यादा आ रहा है। तो ऑल दिस थिंग्स यू काउंसल बिफोर स्टार्टिंग ट्रीटमेंट। ड्यूरिंग ट्रीटमेंट इफ यू ट्राई टू काउंसल, इट इज नॉट बी इफेक्टिव, बिकॉज वो सोच सकता है पेशेंट कि ये अपने को सेव करने के लिए बता रहे हैं। अगर आप पहले से उसको माइंड मेकअप कर रखेंगे तो दिस इज हेल्पफुल फॉर योर ट्रीटमेंट पॉइंट ऑफ व्यू। सो आई एम नॉट टेकिंग मच मोर टाइम. Proper assessment, it is a general fundamental principles of the any disease for the assessment, like proper clinical history, proper past history, local examination, and some relevant investigation. Not all. Like in present scenario, the majority of the person do advise the MRI. Some patient having simple cutaneous fistula with the MRI report. It is not be essential. When there is need, yes, I am closing just one or two slides. So there are different way of the planning of treatment. I'm not going in detail. If the time is permit, in future I will discuss all these things in detail. So with these words, once again I am very much thankful to the organizer who has given me time for the interacting my view in front of the learned audience. Thank you very much.
Thank you, sir, for this insightful presentation. Now, I would like to invite our chairperson, Professor Ajay Gupta sir, to please conclude this session. Please, sir.
ये आपका काम नहीं कर रहा है। Hello. Hello. Yes, yes. So, thank you very much. All the speakers, we had 3 speakers in this session. First lecture was oration from Dr. R.K. Jaiswal from BHU. His topic was acid-base abnormalities. In this, his oration, he described different causes, diagnosis, and clinical management. And he also highlighted the importance of acid-base balance. And he gave a special emphasis on the regarding the pH level on our body and how to manage these conditions. So I congratulate Dr. R.K. Jaiswal for his nice presentation. Next presentation was a very detailed presentation by Professor P. Hemant Kumar. He is not only head of the department in NIE of Shalyatantra, he is also Pro Vice Chancellor and Dean PG also. And during his life, he has given a lot of contribution as far as Shalyatantra is concerned. So he has given a detailed, very detailed and quick description regarding the various surgical practices in Ayurveda and what is the current scenario, which was very, very motivational for the young students. I hope the students will take seriously and follow the principles, the aspects which he has mentioned of Acharya Shushra, not only the surgical, parasurgical, he also highlighted the laparoscopic techniques, the laser techniques, and also the Sandhan Karma. I also congratulate Dr. P. Hemant Kumar for his wonderful, excellent presentation. Third lecture was by Professor Shishji Gupta sir, who is also a very, very senior person from IMS BHU Department of Shalyatantra, ex-head of the department, and has got a lot of exposure, not only in general surgery, parasurgical surgery, and he is a master of laparoscopic surgery also. And he highlighted the do's and don'ts in the management of fistula in NO. A very important line which he mentioned, treating a patient of fistula is NO is not just only passing a thread from internal to external opening, but it requires a very, very meticulous observations. So this is a very, very learning approach which he has highlighted in his lecture. I congratulate him also for his presentation. Thank you very much.
Thank you, sir. To conclude this session, now I would like to request our principal, Professor Vinod sir, to please felicitate Professor R.K. Jaiswal sir. Please, sir. Sir, please. R.K. Jaiswal sir, please. Next, I request Professor P. Hemanta sir. Sir, please. Next, I would like to request Professor Suji Gupta sir. Sir, please. Next, I would like to request Professor Neelam Gupta ma'am. Please, ma'am. Professor Neelam Gupta ma'am. Anju ma'am, please come on the stage and felicitate ma'am. Next, I would like to request Dr. Anjana Saxena ma'am and Dr. Alka Gupta ma'am. Alka Gupta ma'am, please come on the stage. Anjana ma'am, please. Alka. Now, I would like to request our chairperson, Professor Ajay Gupta sir. Sir, please, Professor Ajay Gupta sir. Now, I would like to request our co-chairperson, Dr. Pankaj Bharti sir. Next, I would like to request Professor Shailen Singh sir. Professor Shailen Singh sir. Sir, please. And Dr. Priyanka Singh ma'am. Priyanka Singh ma'am, please. साथ बस हाँ 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 बस 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 Thank you, sir. Thank you so much. Now this session will be. Now this session is completed, and within few minutes, Neeraj Vani, our cultural activity will be started in within few minutes. Within few minutes, your wait is over.
इधर आ जाओ। सर तो आ गए ना? ये ऑन है कि नहीं ऑफ है? ठीक है ऑन है। शुरू करें?
पहले
इसको हटा
प्रैक्टिस
देते
कर
हैं।
लो, पहले प्रैक्टिस।
नहीं नहीं चाहिए, माइक चालू है।
ये भाई बंद कर दो क्या?
नहीं देख लो, बंद कर दो, 2 मिनट के लिए बंद कर दो। मैं सर को चले?
करती हूँ ना? करती क्या?
नहीं है, नहीं चाहिए, ठीक है।
बंद करो क्या?
नहीं भाई,
मेरे को बोलो ऐसा
तुम इधर आओगी, तुम इधर आओगी।
नहीं, मेरा
हाँ। शुभ संध्या। शुभ संध्या। माननीय मुख्य अतिथि महोदय, आदरणीय अतिथिगण, देश प्रदेश से पधारे विद्वान प्रतिनिधिगण, सम्मानित आयोजक मंडल एवं मेरे प्रिय साथियों, मैं अभिषेक शुक्ला,
मैं साक्षी गुप्ता,
बीएमएस फाइनल प्रॉफ के स्टूडेंट्स, आप सबको सादर प्रणाम करते हुए आप सबका इस सांस्कृतिक कार्यक्रम कालांजलि में हार्दिक स्वागत एवं अभिनंदन करते हैं।
आज हम सब यहाँ एक राष्ट्रीय सेमिनार के शुभ अवसर पर एकत्रित हुए हैं, जो ज्ञान, विचारों एवं अनुभव के वैश्विक आदान प्रदान का एक सशक्त मंच है। इस गरिमामय आयोजन के साथ जुड़ा यह सांस्कृतिक कार्यक्रम हमारी समृद्ध परंपराओं, विविधताओं एवं मानवीय मूल्यों की सुंदर अभिव्यक्ति है।
संस्कृति किसी भी राष्ट्र की आत्मा होती है। यह हमें जोड़ती है, समझ बढ़ाती है और सीमाओं से परे जाकर कला, संगीत और नृत्य के माध्यम से संवाद स्थापित करती है। आज प्रस्तुत होने वाले सांस्कृतिक कार्यक्रम न केवल हमारी भारतीय विरासत को दर्शाते हैं, बल्कि वसुधैव कुटुंबकम यानी कि संपूर्ण विश्व एक परिवार है, इस भावना को भी सुदृढ़ करती है।
हमारे लिए गर्व का विषय है कि इस मंच पर विभिन्न प्रदेशों के प्रतिनिधि
थोड़ा सा-
उपस्थित हैं।
Volume-
आपका यहाँ होना
हेलो,
इस आयोजन की राष्ट्रीय गरिमा की ओर और ऊंचाई प्रदान करता है। हमें आशा है कि यह सांस्कृतिक संध्या आप सभी के मन को आनंद, सौहृदय एवं आपसी समझ की मधुर स्मृतियां छोड़ेंगी। इसी आशा के साथ
हेलो।
आज इस कार्यक्रम का शुभारंभ करते हैं।
ठीक ठीक, थोड़ा सा वॉल्यूम हल्का सा, हाँ हल्का सा, हेलो हेलो, थोड़ा सा ही।
आयुर्वेद में ऐसे तो बहुत से बहुमुखी प्रतिभा के धनी होते हैं, लेकिन एक चिकित्सक और संगीतज्ञ एक साथ होना और वो भी दोनों विधा में समान ख्याति प्राप्त करना बहुत दुर्लभ की बात होती है। ऐसे ही बहुमुखी प्रतिभा के धनी मृदुभाषी, बल्कि यूं कहें कि मधुर भाषी प्रोफेसर डॉक्टर नीरज खन्ना सर, जो पूर्व में हमारे संस्थान के काय चिकित्सा विभाग के प्रोफेसर एवं विभागाध्यक्ष रह चुके हैं, जो पहले तो अपनी मीठी बोली बोल के डायबिटीज करवा देते हैं और फिर खुद को डायबिटीज स्पेशलिस्ट बताते हैं और उसका इलाज भी करते हैं। ऐसे सदैव प्रसन्न और मुस्कुराते रहने वाले खन्ना सर को हम आमंत्रित करते हैं कि वो अपनी टीम के साथ मंच पर प्रस्तुत हों और हमारे कानों में एक शहद घोल दें। मैं अनुरोध करूंगा डॉक्टर नीरज खन्ना सर से कि वो आए।
आप सबका नाम
और-
बता दीजिए।
जी सर,
पढ़ पा रहे हैं ना? हाँ
हाँ हाँ। गायक हमारे कमलेश चौबे बाबा, तबला वादक गुरुदयाल जी, कीबोर्ड श्री रंजन दादा, पैड संभाल रहे महेश जी साहिल और ढोलक वादक श्री प्रमोद पांडे जी का हार्दिक स्वागत एवं अभिनंदन करते हैं। मैं चाहूंगा आप सब जोरदार तालियों के साथ नीरज खन्ना सर की सुंदर प्रस्तुति का आनंद लें।
चेक करिए।
चलो चलो मैनेज करो। मेरी आवाज सुनाई दे रही है आप लोगों को? मैं डॉक्टर नीरज खन्ना काशी से आया हूँ। इनको भैया कम करो जरा। और बताने आया हूँ कि प्रयाग हमारी जन्मभूमि है और काशी हमारी कर्म भूमि। तो जन्मभूमि और कर्म भूमि का भी ये संगम है। और ऐसी माँ गंगा मैया जिन्होंने हमको यहाँ भेजा है अपनी जन्मभूमि पे, मैं माता पिताजी के चरणों में प्रणाम करता हूँ। भगवान धन्वंतरी माँ सरस्वती के चरणों में प्रणाम करता हूँ। और माता पिता और गुरु जिनकी अनुकंपा से ये शुभ दिन आए हैं, हमको भी प्रणाम करता हूँ। और कभी कभी ये इंसान के हृदय में बात आती है कि मैं माता पिता गुरु कहूं किसको, जन्म देने वाले को कि पालन पोषण करने वाले को कि ज्ञान देने वाले को। तुलसीदास जी ने इसका समाधान किया है। थोड़ा वॉल्यूम बढ़ा दे बेटा, बात करो, थोड़ा वॉल्यूम बढ़ा। तो उन्होंने कहा है कि गुरु पितु मातु महेश भवानी, गुरु पितु महेश भवानी, गुरु पितु मातु महेश भवानी, भवानी, गुरु पितु मातु महेश भवानी, गुरु पितु मातु महेश भवानी, प्रणवहु दीन बंधु दीनदानी, प्रणवहु दीन बंधु दीनदानी, गुरु पितु मातु महेश भवानी, प्रणवहु दीन बंधु दीनदानी, गुरु पितु मातु महेश भवानी, अनुदिन बढ़ो अनुग्रह तोरे भवन मंगल भवन मंगल हारी प्रभु सुदशरथ काशी से हमारे कमलेश बाबा चौबे जी आए हैं, इनके लिए जोरदार ताली होनी चाहिए क्योंकि ये काशी के बहुत बड़े कथावाचक भागवत गायक हैं और बड़ी उनकी अनुकंपा है कि हमारी जन्मस्थली पे आए हैं। आप सुन करिए। जैसी बात ये कितना रहा कम करने दें। आइए सबसे पहले बाबा गणेश का आवाहन करते हैं, बड़े भाव से मस्ती से गाते हैं, अपने हस्ती को भूल करके कहना है। इसको चालू कर दीजिए। ये देखो जरा की पे दे दो। अरे गौरी के पुत्र गणेश जी मेरे घर में पधार, गौरी के पुत्र गणेश जी मेरे घर में पधार, श्री गणेशाय नमः, श्री सरस्वती नमः,